Where do we leave off?
I mean, I know where we left off. Should I just keep on going?
I think so, because we got them on tape.
So I got the
We're
videos.
going to start the library.
All right.
So I think so.
All right.
That wasting time.
Great. All right. Well, good morning, everybody. Sorry for the delay.
Good morning.
We spent the first couple of talks on subarachnoid hemorrhage. I thought the first of these series of lectures would be as one is a broad overview of aneurysmal subarachnoid hemorrhage, or subarachnoid hemorrhage to begin with, because that is obviously one of the most common diagnoses that we take care of, and we're not only a regional but a national referral center for subarachnoid hemorrhage. So my point was not to go into immense detail on every area of the medical and the neurologic aspects of subarachnoid hemorrhage, but as just a three-lecture sort of tour de force through an overview, with some detail certainly. And then, as the rest of the year goes on, we can go into individual topics like sodium management in the ICU, like vasopressor management in the ICU, like vasospasm specifics in protocols and whatnot, and we can get more granular and dig down. But for now, so this is part 3, and I think that we should, well, we may have to leave early because I'm late, but this is where we left off. We left off on subarachnoid hemorrhage management, and what we, is that me or someone else? Let me just get that. Cardiac. And I thought we'd go into fluids, sodium, vasospasm, and then some miscellaneous medical issues to sort of finish up. And we have till what time? 8:30? Or 8:15?
8:30? Yeah.
Okay, all right. So, in general, at the end of the day, with somebody with a subarachnoid hemorrhage, if left untreated, either at home or in the hospital, and we weren't paying attention to what was going on, at the end of the day, they would be volume contracted and hyponatremic. So that is the rule, not the exception, and there are many reasons for that. One of the reasons is that in GFR, which is in the kidney, the glomerular GFR, so the GFR ends up going up, and you end up clearing a fair amount of sodium and water from the kidneys. What happens is you get a pretty profound sodium diuresis or natriuresis, and you lose water and salt. So the question is, well, why don't you become hypernatremic if you're losing all that water? Well, sooner or later you will. But in the middle phase, which is when we end up seeing them, you'll end up losing a lot of salt. Often you'll lose some water, and you'll overall be contracted. Well, that's the worst possible state you could want to be in if you've got cerebral vasospasm, so your overall plasma volume is down. There are other reasons as well. Your ADH goes up, you retain free water, and you become hyponatremic. So there are many things that actually go on simultaneously, some of which is to retain salt, some of which is to lose salt, some of which is to retain water, some of which is to lose water. So there's a balance, and the balance of the neuroendocrine balance shifts really from day to day. So if you, and we'll talk about this in a few minutes, but if you said, well, are they salt wasting today? Are they in SIADH today? And the answer is yes, because it really does change. And if you measured ADH levels, you measured sodium, you measured serum osmolarity, things would really be somewhat of a seesaw. And there's still actually a fair amount that's unknown about this. But at least in the early phases, it's very clear that you lose a lot of salt, which is why you see us giving salt back all the time, whether it be in salt tablets or 3% or 23% or whatever it is. In general, the first rule is correct the volume contraction or prevent further volume contraction. So, everyone, even in the setting of cardiac dysfunction, goes on some IV fluids. 75 cc's, 100 cc's, 125 cc's, whatever it is. There's no actual number that is a target. It's targeted for that specific person's eyes, nose. But if it looks like they're just putting out a lot of urine, then you're obviously going to have to compensate for that. Isotonic fluids are the rule. You'll see if our patients float to other units or if you go to other ICUs, half normal saline or D5 half normal saline is a fairly, or lactated ringers, is a fairly standard solution. That's never the solution, or almost never the solution in neuro, because you don't want to actually worsen the hyponatremia that the person's already vulnerable to with giving them free water. Now, free water through the gut is a little different because it's absorbed and then it's equilibrated with the body. But free water intravenously, direct free water into the intravascular space is not good. We'll talk a little bit about it later, but avoid dextrose obviously is a big deal. Sugar in general is bad for critically ill patients, and it's particularly bad for patients that are at high risk for neurologic injury. So the one thing that will make ischemia worse or extend an infarct is a high blood sugar in the setting of that ischemia. Saline or colloids, we'll talk about that in a few minutes, for volume expansion and obviously correct sodium losses. So, hypernatremia is overall the worst thing that you could possibly have. If you've got somebody that's hypernatremic, and that's hypernatremia before we've treated them. I'm not talking about induced hypernatremia for cerebral edema. That's different. I'm talking about hypernatremia all on their own. Sort of nurse and doctor-induced hypernatremia is different in the ICU. That's usually not in the setting of volume contraction. That's in the setting of giving lots of fluids and lots of salt. But if you left them alone, hypernatremia would mean that they were so profoundly volume contracted that despite their salt loss, they were hypernatremic anyway, which would be a severe state and hard to bounce back from. Unlike other critical care populations, hyponatremia, is way more common than hypernatremia, 40% versus 19%. Hyponatremia is associated, as I say, with decreased plasma volume. So again, decreased volume, decreased sodium. Hyponatremia is associated with significant salt loss, and hyponatremia is associated with poor outcomes. So it's somewhat of an academic exercise, but it is important to go through, is if you look at the differential diagnosis in a critical care population, although there are more reasons than SIDH and salt wasting, those are the two biggies. And most of the time, it's SIDH, except for subarachnoid hemorrhage. So brain tumors, Guillain-Barré, meningitis, ventriculitis, other kinds of things, TBI, those are all neurologic syndromes or diagnoses that are associated with serum of inappropriate ADH, which means that you've got too much water and you're hyponatremic. Aneurysmal subarachnoid hemorrhage is relatively unique in that it gives you salt wasting. So let's just talk about what SIDH is. SIDH is when you have euvolemia or often hypervolemia. So SIDH, again, is ADH is antidiuretic hormone, right? And what does antidiuretic hormone do? It acts at the kidneys, in the collecting ducts, at the end of the whole kind of urinary system to take water back. Right? So in general, people with severe SIDH